Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Janet Jokela, former treasurer of the American College of Physicians and infectious disease physician. And we're going to talk about measles, why
Great.
vaccination is more vital than ever. Janet, welcome back to the show.
Thank you so much, Kevin. Delighted to be here.
All right. So, as I was prepping for this episode, a convenient article in the New York Times, I'm sure that you're aware of yesterday. We are speaking on July 10th. So, yesterday, measles cases hit highest total since U.S. eliminated the disease. There have now been more measles cases in 2025 than in any other year since the contagious virus was declared eliminated in the United States in 2000, according to new data released by the CDC. So, if that context, what is your article about?
Thank you, Kevin. Yeah, it was a sobering article to see and sobering data to hear about. With the measles cases that have been erupting this spring, it brought me back to my fellowship when I saw a case of measles and just what was involved in all of that. So, again, as a fellow, infectious disease fellow in Boston, I was called in the middle of the night and the nurses said, "Oh, I think we have a case of measles." And I was like, "Oh my goodness," because that was not on anybody's radar. We weren't talking about it. We weren't really thinking about it. I thought, all right, I've got to go in. I'm going into the hospital in the middle of the night to see this patient. So that's what I did. And before I left, I reviewed a little bit about measles because, again, it wasn't something at my fingertips. But go in to see the patient. They put the patient in a respiratory negative pressure room, which is absolutely the right thing to do. And this individual was a teenager. They were visiting with their high school group from a local, we'll say an adjacent country.
Uh-huh.
And they were visiting, they were part of a musical group actually, and they were playing in venues across the city of Boston, including nursing homes. All right. So this is potentially a major infection control related issue. So at any rate, I go in to see the patient and she had all the stigmata. She had a rash, but also her eyes were red, her nose was running, she was coughing, and and anyway, so there we are. I looked at her mouth. She had Koplik spots. I had read about Koplik spots. I never had seen them. As soon as I saw them, it's like, oh my goodness, that's pathognomonic. This is measles. So there we were.
Wow. So I think that measles, we always think it's one of those cases that we only read on board exams and textbooks. But of course, we're seeing an increasing number here in the United
Yeah.
States, of course, with the CDC data. So tell us to get everyone on the same page. Just give us just a brief synopsis of the virus that causes measles and just give us a little bit of background.
Yeah, yeah, yeah. Indeed, it was eliminated in the US or declared eliminated in the US in 2000, meaning that there were no ongoing episodes of transmission. And it's been that way ever since for 20 plus years. The virus is highly contagious. It's one of the most contagious, if not the most contagious respiratory viruses that we know of. It can infect, say, 9 out of 10 susceptible people if people are in the same room, same area, if they're exposed to it. And even if a patient with measles has left the room, people within that room, say within the subsequent 2 hours, they can be infected. I mean, the virus can essentially hang in the air. And, in many ways, you'd think, all right, if it were a common cold, all right, so be it. But that's not measles. Measles can cause disability, it can cause death, certainly in young children, also in adults. So it's a really big deal that this is happening.
And we often hear about the death part, but there's a big disability part as well. So specifically, what disability complications
Yeah.
can we be aware of?
Right, right. Deafness can be one thing that can develop if someone has untreated measles and well, there's no treatment for measles, but if someone develops measles and complications of ear infections and all that. So deafness, but also the neurologic things are, I think, what really scare people. So approximately 1 in 1,000 people who are infected with measles can develop encephalitis. So it could either be acute encephalitis or acute disseminated encephalitis, and that can lead to neurologic disability long term. And then there's the scary subacute pansclerosing encephalitis, much more rare, but that can pop up out of nowhere like 7 to 10 years later, and that often can lead to profound disability or death. So those are some of the scary things that can happen disability wise.
So Tell us when the vaccine, the MMR, measles, mumps, and rubella vaccine, when was that first introduced, and what was life like before that vaccine?
Yeah, great question, Kevin. The vaccine was first introduced in 1963. Today we have an improved vaccine that's been in existence and been in use since 1968. So before 1963, before the vaccine was developed, there were deaths in the United States, 400 to 500 deaths per year in the US due to measles. Thousands of people catching and children catching measles. It was just so contagious. Once it got into a population, in essence, it was really impossible to stop. So infections were common. And then the sequelae, pneumonia was the most common cause of hospitalization. And also that can lead to more progressive illness and also death as well, respiratory failure. So it was just a real scourge, particularly in the pediatric population.
And of course, the vaccine was fabulously successful. Like measles was considered eradicated for a period of time. Is that correct?
Not eradicated, but eliminated from the US. There are still pockets around, and certainly around the world, there are pockets of measles as well, just because of varying levels of uptake of the vaccine. So it was eliminated in the US. It wasn't eradicated. The only virus that's been truly eradicated is smallpox. And there have been efforts for a long time to eliminate polio, for instance. So anyway, there are efforts in those directions, but it was eliminated in the US.
So you also talk about the concept of herd immunity. So I think that it's not just the shot itself, but the community receiving the shot. So talk more about the percentage that the community needs, the percent immune that the community needs in order for the whole vaccine to be effective.
Thank you, Kevin, for asking that question. Absolutely. The level of herd immunity that's understood to be effective for containing a measles outbreak is 95%, which means that 95% of the persons within a given community must be immunized to prevent ongoing spread of measles. And so if you look at the CDC's website, there's some really nice maps there that show the level of MMR vaccination in kindergartners across the US by state over the last 10 to 15 years. Those levels have dropped in various states, in large part due to the fact that there have been non-medical exemptions which have been approved by state legislatures, so that in many ways the vaccination rates have ended up dropping below that 95%. And then now we're in the situation where we are today, where there are pockets where the vaccination rate is less than 95% in certain areas in various states, and here we are.
And how much less than 95%? Are we talking about the low 90s, high 80s? What number are we talking about in order to get these outbreaks?
Yeah, that's a really important question. When you look at the maps at the CDC, they have the maps from 95% or higher, and those are blue states. And then there's light orange from 90 to 95, and that's kind of light orange. And then below that is a darker orange color. So that said, it's highly variable. And, there are pockets in any state that may be highly vaccinated and other areas which may be less vaccinated. And so because it's so contagious and, it can linger in the air in a room, if someone who's unvaccinated goes to that, is in that same room, they may be infected and may contract measles as well. So in terms of the values, it's highly variable. In Illinois, the rates overall are in, say, the between 90 and 95% in that region. But also in Illinois, even we have data down to the individual schools in Illinois and the individual counties. And there's high variability within the schools of vaccination rates in the schools. So it's highly variable.
And from your understanding and what you've heard, what are some of the major reasons why people are hesitant or resist receiving the vaccine?
I think people they've been confused. Actually, they've been confused, and there's been concerns raised by a number of people in very prominent positions that actually have sent out confusing messages about vaccines and vaccinations. I think the situation with the COVID vaccine has made people more hesitant about other vaccines. So I think that's been problematic and a challenge for us in healthcare. I mean, to try to mitigate and try to address and correct any mis or disinformation. The MMR vaccine does not cause autism. Unfortunately, there had been a paper published in Lancet, which has since been retracted, which addressed that issue, and that caused confusion actually all over the world. And we're still dealing with the repercussions of that. And then there's been some very well-funded, well-organized entities that really have been sowing confusion about vaccines. And I think people have just been confused, and it has bled over into this very safe vaccine, which the MMR vaccine is.
So you mentioned that the MMR vaccine does not cause autism. What
Correct.
specific misconceptions can you also refute?
Oh my goodness. How much time do we have? So we'll say the MMR vaccine, the immunity is durable. Okay, it's durable, and it does not cause autism. It does not cause death. Those are some very really key fundamental points that I think it's important for patients and parents and all of us to know. So those are some key ones which I think are really important.
Are there any alternative treatments that are valid? Because I know some anti-vaccine proponents, they also tout some alternative treatments other than the vaccines that can address measles. Are there any, as far as you know, that have any validity?
Well, no. Okay, here's the issue. There's been a lot of discussion about vitamin A this spring as well, this spring, early summer. And in fact, unfortunately, we've seen parents, well, not parents, we've seen children develop signs of vitamin A toxicity, I think on the part of well-intended but misguided parents. The issue around vitamin A is that there has been some data reported, more from the developing world, but say children who have been malnourished, who have developed measles, and then they receive vitamin A and they have done better. So that said, there's data that supports doing that in malnourished children. That's it. What the CDC is recommending now, if someone is diagnosed with measles, 2 doses of vitamin A would be appropriate, but again, that should be done under the guidance of a healthcare professional. Not, I would advise against parents going out and administering vitamin A on their own, because vitamin A toxicity can be a real problem and can cause liver issues and other things. So the vitamin A could be used just as a kind of supportive adjunctive treatment, if you will, but it doesn't treat measles itself.
Now, I think just as important as the science and just as important as refuting some of this misinformation is, of course, communication. And you obviously have a lot of experience with that. You are with the American College of Physicians. So, what are some obstacles that we have in terms of communicating some of this science to the country? Like, what have you learned over your years with the American College of Physicians and your work with public health in terms of some of the obstacles in communicating science, and how can we overcome those obstacles?
Kevin, you're the master of communication. All right. That said, and this issue is one that I personally have been grappling with. I think many people have been grappling with, and I think it's the issue of our time. How do we do this? How do we, as informed physicians and scientists and biomedical scientists, how do we do this better to communicate the value of what we do and also the knowledge that we have that we know can save lives and can really help people? There's a few things that come to mind, and I know the ACP has been working on this and address this. There's a gazillion things on the website that address all of that as well. I think meeting patients where they are, meeting them in the exam room, and if they're hesitant, say, that doesn't necessarily mean that they're refusing the vaccine, but it's more like they have questions. They want to know, they want to know like what we would recommend. If we were in their shoes, what would we do and why? And I think also it's critical for us to be curious. So again, in the same vein, to try to explore more, why is the patient hesitant? Why do they not want the vaccine? And try to address those concerns as best as possible. I think it has to start there. In addition, I'll say there was a lovely New York Times article by Craig Spencer, Dr. Craig Spencer,
Mhm.
just the other day as well, talking about the key ingredient of empathy. We have to be empathetic with our patients and not shame them, not embarrass them, but truly try to meet them where they are so we can help impart what we know could be life-saving information.
So, as you know, everything is so politicized, right? And someone on the opposite end of the political spectrum, sometimes it's hard to have that empathy in today's society. So talk to us about some tips in terms of how we can do that, especially in the exam room.
Yeah, again, that's a really important question, Kevin. And as I reflect on this, fully expecting that we'd be talking about this today, it seems that we have to dig deep. It's a personal thing. We have to dig deep within ourselves and find that strength to do that. And if we need to count to 10, we may not have time. We may not feel like we have time to count to 10, but count to 5, count to 10, and
Hmm.
just gather ourselves and try to do that. And perhaps schedule another appointment if more time is needed to talk about these things. And also, I think to work together with our teams, we want to make sure that our teams, our nurses, the people checking in patients when they come in, all that we're all on the same page. We don't want any people amongst our teams kind of conveying an alternative message. Fact is, we can't do this on our own, but we have to ensure that our teams are unified in what we're trying to do and why we're trying to do it. And if our teams aren't unified, then try to find out why and work with them. And again, I think it just requires digging deep within ourselves to find that patience and that core of empathy that is really needed, I think, in this moment.
I talk to a lot of physicians who are getting discouraged because science and what they try to do in the exam room is so politicized. So maybe you could inspire us. Do you have a success story where you had a constructive, or this is a story that your colleagues, from your colleagues as well? What is a story of a constructive conversation with someone who had reservations and hesitancy about the vaccines and not necessarily changed your mind, but you felt you moved that needle in the conversation? What would be an example of a constructive conversation that you've had?
Yeah, yeah. Thanks, Kevin. The one that comes to mind, strongest or most strongly for me, was one that I had with an HIV infected patient of mine who was very hesitant about the flu shot. Okay, and with that, I had developed a relationship with him over a number of years, and that helped. And so he continued to come back to see me. I would broach the topic of the flu shot, and he'd say, "No, no, not today." I said, "Okay," but I told him, look I'm going to continue to ask you about this. If you don't want it today, that's fine. If I were in your shoes, I'd want to get it. We're going to continue to discuss this as we, discuss everything else. And then we went on to talk about his viral load, adherence to his medications and all that, and he was good with all that. So he continued to come back to see me, and eventually one day he said, "Oh, I'll get the flu shot today." And Kevin, I nearly fell out of my chair. It's like, what? Did I hear you correctly? And I think I even joked with him about it, like, really? He said, "Yeah, it's fine. I'm ready. You've talked to me about it. You've been persistent. You've respected me. You respected my opinion, and that's important to me. And I'm going to get it today because I trust you."
And
So
I think that really resonates with me because sometimes, in order to change minds, it isn't necessarily something that you read in a newspaper. It isn't necessarily an advocacy campaign or an influencer online, but it's really the relationships that physicians specifically have in the exam room with that patient, and that has to be developed over time.
that's exactly right. That's exactly right. And some of the reading I've been doing recently, Paul Farmer had some wonderful, beautiful things to say about some of this. But one quote of his was that trust must be built with one patient at a time. And you think what he did globally and organizing all
Mhm.
these big organizations and all this, that was his take on trust.
We're talking to Janet Jokela, infectious disease physician and former treasurer of the American College of Physicians. Today's Kevin MD article is Measles is Back, Why Vaccination is More Vital Than Ever. Janet, as always, we'll end with some take home messages that you want to leave with the Kevin MD audience.
Sure. Thank you, Kevin. I think it's important for us as clinicians to be aware that measles is out there and to be familiar with how it presents, what the symptoms are, and how we can address this. So, in essence, vaccinate. And to do that, I think to meet our patients where they are, be empathetic, really listen to them and work with them to try to understand whatever hesitations they may or may not have. So that's it. Thank you.
Jen, as always, thank you so much for sharing your expertise and perspective. And thanks again for coming back on the show.
Thank you, Kevin. Delighted to be here.